Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts. Today's topic is about heart failure and recent advancements in the field. And joining me today to talk about this is Dr. Syed Mehmood with Red River Cardiovascular Surgery. Thanks for being here, doctor.
Thank you for having me.
Absolutely. So you are a cardiothoracic surgeon,
Yes.
correct? And tell me a little bit about what you do at Red River.
I am, well, there are four of us, and we all have different areas of expertise. I am actually Director of Structural Heart at Willis Knighton Hospital, and I do half open, half endovascular treatments for whatever is broken in your heart.
Okay, so you kind of cover it all. So, but you also mentioned that maybe even
Esophageal surgery
Okay.
can be done by my field. I personally don't do it. So.
Okay, gotcha. But maybe one of your colleagues would at Red River.
Yeah.
Yeah. Cool. Very interesting. So, what maybe made you decide to get into cardiothoracic surgery? I mean, it sounds like it's pretty complex.
It is, and I actually enjoy it.
Yeah.
You know, with heart surgery is, if nature makes you, and it's not like a foot that hurts and you can keep on walking on it. If your heart is failing, you have to fix it. Otherwise, you don't do well, and it's almost instantaneous results. So especially if you do an endovascular procedure to fix your heart. I mean, sometimes the next days people come give me a hug and say, "I feel so much better, doctor. Thank you for helping me."
Yeah, so it's probably really rewarding as
Yes.
well.
Yeah, it's instantaneous reward, unlike medicine, which takes a long time.
Yeah. And so you mentioned you see a lot of patients that maybe their heart is failing, and you can do a lot of these procedures to help them. And so that's kind of what we're talking about today is heart failure and maybe some of those recent advancements that you've personally seen in practice. And so tell me a little bit about, you're the head of the structural heart clinic, right? And
Yes.
Red River. So tell me a little bit about what that clinic is and how it can serve this community.
Sure. Structural heart is, there are two parts of the heart, the blood vessels and the actual structure. Like there are valves in there, there are 4 valves, and there's different muscles and different, just different chambers of the heart. Structural heart is anything related to the actual structure and not the blood vessels. Structural heart clinic is something that we have established and we value at Willis Knighton. It's a multi-modality, meaning I, as a surgeon, am part of it. There's actually a couple of cardiologists, invasive, that are part of it. There's a special imaging cardiologist that are part of it. And each case that gets referred to the structural heart clinic gets all 3 of our expertise in different fields, and then we all come to a consensus what is the best way to treat what you have.
Yeah. Go ahead.
And then, like you mentioned earlier, we've done almost, when I came over here, we had the celebration for the first 100 TAVRs. Now we're going to be crossing the first 1,000 TAVR next week. So that's come a long way. We are actually a regional referral care center, meaning we've had referrals from all the way from Jackson to Lafayette for things that could not be done in the local community, that we, being a more of a tertiary referral care center, can take care of more complex patients.
Absolutely, that's pretty interesting. And we'll talk about TAVR in just a second, but structural heart, so you mentioned you get referrals or patient referrals for this clinic. Now tell me a little bit about the patients. What diagnosis do they have, and what is the typical patient that you would see in this clinic?
Most of the patients we see are older. Young people can have a valve problem, other problem, but it's much, much rarer. Let's say 80%, 90% are people in their 60s to 90s. And again, with structural heart, especially endovascular, we've done 109-year-olds. You can do okay with that. I'm exaggerating. Maybe it was 101, but it was in the hundreds for sure.
Wow.
The typical symptoms you can have depends on the valve that's going bad. If it's the mitral valve that's going bad, that you start out with 1 pillow, then you go to 2, you go to 3 pillow. Walking very short of breath after you walk to your mailbox is a very common complaint. Other complaint is your legs start swelling. So that's more symptoms of the right heart failure, but that's precipitated, or that's because the left heart's backing up and it's causing issue. The other thing you can have is, if it's the aortic valve, you can have a syncope, which means you just faint, or you can have palpitations, or you can have a high blood pressure, or it could actually lead to heart failure, meaning your heart starts getting weaker and weaker and weaker.
So most of the time you are seeing patients that have that heart failure diagnosis, and
Yes.
it kind of just depends on where in the structure of the heart that
Yes.
is failing.
Yes.
Right. Okay. Very interesting. And so TAVR is one of those procedures that's been very successful and pretty extraordinary that you guys are almost at that 1,000th mark. You mentioned that you probably have done about 600 of these procedures.
Yeah, off the top of my head.
Yeah, right. So tell me a little bit about TAVR, maybe what it means and how this procedure is helping patients.
I'll give you a little history. In
Okay.
2007, when I was in residency, going to cardiothoracic, it was starting to come out. It wasn't approved. It really was. Somebody came up with the idea that do you really have to open somebody's chest up? That's what we're doing. What we have been doing as surgeons from the 60s. Can we do it in really high risk patients without opening somebody's chest up? So we put this thing on a balloon, crimped it, and put it in, and it worked. And then, but the technology over the last 14 years has gotten a lot better. Previously, it was much bigger. Now we can do it smoother, better, faster, with much better results. And especially in older patients, if you're over the age of 65, we recommend TAVR for most people. If you're younger, then maybe there's still value for mechanical valves and open surgery still. So, and even the last 3 years, there've been a lot of advancements. The new valve lasts longer, leaks less. So.
Gotcha. Well, that's very interesting, and we'll talk a little bit more about it. But for now, if you're just joining us, Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. And we'll be taking your calls and answering any questions that you have live in the studio today with our doctor. We have those phone lines open right now. That number to call is 318-219-4569. When you do call, please make sure you're in a quiet room with your TV turned all the way down so that we can actually hear your question. And again, we are talking with Dr. Syed Mehmood, and we're talking about heart failure and a structural heart clinic that you actually run right here in Shreveport. So give us a call if you have a question for him. And so we're talking about structural heart, and you mentioned when you were in residency, TAVR was something that was coming out, and now it's standard, right? It's kind of standard of practice. But it's not maybe found, is Willis Knighton maybe one of the only places locally that has this procedure?
Well, 6 years ago we were. Now there are 3 of us. But if you go to MitraClips, or especially if you go to some of the new devices that we have, Pascal, I think we'll be the first system in the city to start having TriClip, which is something we are actually starting to go into training for next week. So it's new stuff. We're always trying to innovate, and then others catch up, and we try to do the next thing.
Yeah, that's pretty awesome. You kind of set the standard, if you will. So TAVR, correct me if I'm wrong, but it's kind of a procedure to help mitigate the opening of the chest cavity, so you're not having to go under this really, really invasive surgery, right?
You're awake when we do it.
Oh, wow.
Yeah,
okay.
So we just give you...
Go ahead.
We give some local, and we do the procedure, and then you're awake in a few hours. 6 hours later, you're walking. Some people get discharged the same day.
Okay, pretty awesome. Well, Dovey is on the line. Thanks for joining us, and what's your question?
Well, I don't really have a question, but I wanted to tell Dr. Mehmood, you operated on me in May of 2021. I had a triple bypass and a heart valve replacement, and I'm doing very, very well, and I wanted to thank you so much, because my life has really been a lot better since then. And I turned on today. I turned on today just to watch you today, and I wanted you to know that I'm very grateful.
Ms. Duffy, thank you so much. You just made my day.
That's
why I do
so
it.
sweet.
Thank you. All right. Thank you very much. Bye-bye.
That's so kind. Go ahead. You might have wanted to say something else.
No, I'm just saying this is why I do it. Most of the procedures we do, it makes a big difference in patients' lives, and they know.
Yeah, that's awesome. Well, now we have another caller. Gladys, thanks for joining us. And what is your question or comment?
Well, first of all, I'd like to know where he's located, which hospital that he's practicing medicine in.
Willis Knighton, ma'am. Willis Knighton North, which is the old Willis Knighton.
Willis Knighton North. Oh, okay. Well, my question also was, is there any relationship or connection with hypertension and hypoxia and subdural hematoma?
What kind of hematoma, ma'am?
Subdural.
Subdural. Well, if you
hematoma.
Yes, ma'am. Well, subdural can be, if you have really high blood pressure, it can happen.
With high blood pressure?
It can. You know,
okay.
Especially if you get into an injury or you have soft vessels. But, you know, that's not my field of expertise. That would be more of a neurosurgeon question.
Well, there was hypoxia. I guess the hypoxia was related to the subdural hematoma. Would that make sense?
Yes, ma'am. I mean, you can have hypoxia in some part of the brain, especially if you're having some swelling or some compression.
Yes. Well, this is a family member, and this family member had pulmonary embolus and atrial field and all that, you know, was cause of his death. And I just wondered if hypertension brought some of this on, like the hypoxia and the subdural hematoma, the pulmonary embolus, and the atrial field.
Well, the atrial fibrillation is usually a conduction issue, so it's a wiring, and high blood pressure usually doesn't cause it. It can cause strokes and it can cause other issues. But, you know, all things are kind of related because they all stem from something common. So
you're saying that the hypertension could cause the atrial field?
No, I'm saying one is electric issue, one's a pressure issue. Usually does not cause atrial fibrillation.
I missed that. What would cause the atrial field?
It's the conduction, so it's in the wiring in your heart that goes haywire. I mean, we believe it or not, we're still trying to figure it out and how to fix it. We're not 100% sure. It could be swelling that can cause it. Can be some wires are crossed in your heart that's causing a cascade that makes your rhythm go haywire.
All right, well, thanks for joining us with that question. And if you're just joining us and you have a question for Dr. Mehmood, give us a call at 318-219-4569. And again, we're talking about heart failure and just advancements to help with, you mentioned like valve issues, the structural heart, not necessarily the blood vessels. And so at your clinic, you were able to do the TAVR procedure. Now tell me a little bit about the mitral or mitra clip.
Yes.
And yeah, go ahead.
So the TAVR is designed for the aortic valve, which is the topmost valve. One of the hardest valves for us to fix as surgeons is the mitral valve, which sits behind the heart. And this mitral clip has been around for 8 or 10 years. It's a technology we don't use as much. You can use it in all the patients. Like TAVR is almost universal. It's not an issue. With mitral clip, we are able to help a lot of people who are not surgical candidates for one reason or the other. For you to undergo surgery and do well, you have to be pretty strong. If you're already very, very weak, it's very hard for us to get you through it, or very, very elderly. You know, it's, as we're talking about mitral clip, there are a couple of other devices in trial that we are hoping that will have the same efficacy, or the same results like we can have for TAVR now, but it's still at least 2 years out.
And what about Pascal?
Pascal is a newer version made by a different company, which I think is, we've done like 3 of them at Willis Knighton, just came out maybe 6 months ago. It's just a newer, better version of MitraClip, in my opinion.
Oh, okay. So it does similar things as the MitraClip, just a different version, maybe updated, more advanced?
More advanced.
Okay. And so tell me a little bit about, let's say, someone is referred, so let's just play pretend patient was referred to you, and what then happens? You know, what is the process of, I know you mentioned you have your team that looks at all the different pieces, and then you decide on what, you know, what's going to happen moving forward. What is maybe the most common thing that you see with heart failure, and then the most common procedure that you move forward with?
Yes, ma'am. So, you know, when a person is referred to our structural heart clinic, it's usually referred by a cardiologist, outlying, or maybe a primary care in some instances, we'll look at the history, and we'll see what, even before they come there, what would be the best modality and what treatment we think should happen. Then we'll try to get the right people involved and try to have them have all the studies we need to do that test or the procedure, and the right surgeon. You know, there are like 3 of us, so we'll get the right people involved in the care right then, so they don't have to come back and forth. So, and we try to do it. You know, if you are referred to us this week, we try to get everything done within the week if we can, unless it's like Thanksgiving or Christmas when we physically cannot.
That's awesome, though. Within a week, that's pretty great. Well, we have another question and another caller. Lottie, thanks for joining us. And what is your question?
My question is, I'm calling concerning my great-granddaughter, and she has Marfan syndrome.
Yes, ma'am.
And I'm calling to see if there's anything that they know what to do about that, if it's a heart problem.
Well, Marfan syndrome can have some congenital issues with the heart. Did your great-granddaughter have some heart surgery when she was little?
Her grandmother, one of her grandmothers, and her great-grandmother all had Marfan syndrome.
Okay.
And now she has it. She's 10 years old now. She's had it.
We have to just be careful for, sometimes they can have heart defects, sometimes they can have aneurysms that can rupture. They just need very close monitoring. As long as the pediatrician knows she has Marfan's, he or she should be able to keep a close eye on it. Usually when they get older, in the 40s, when it starts having a problem. Not in all of them, but in some Marfans.
All right. Thank you.
You're welcome, ma'am.
Thanks, Lottie, for your question. And if you're just joining us, you can give us a call at 318-219-4569. We're talking to Dr. Mehmood with the Red River Cardiovascular Surgery, and we're talking about heart failure. So give us a call if you have a question. And what is the American College of Cardiology certification? What does that mean, and why is that important?
So it's a body designed by the Cardiology Association, the American Cardiology Association, that puts at a higher bar. So you have to have diligent monitoring. You have to have system and processes in place that it's just like a superior level of care and superior level of oversight. We just need to have a higher bar.
Yeah.
And customer satisfaction, patients do well, and if there's an issue, we have a system and processes in place to fix that. And we've been certified for 3 years, and we have another certification coming up tomorrow, actually.
Okay, congratulations. And what is this new certification? Can you release that information?
No, yeah, for sure. It just means if they allow us, we'll be certified for another 3 years.
Oh, gotcha. Okay.
Yeah, just renewal.
Okay, so it's every 3 years.
Every 3 years. Every 3 months, we have to send them data. We have to meet internally and with them every 6 months or something. And then they'll monitor us. And if they give you a temporary one, then they give you a 3-year one. And then every 3 years, you have to redo the whole thing again. So.
Well, congratulations for another 3 years. That's exciting.
Well, hopefully.
Yeah.
We'll find out.
Oh, right, yes. Well, that's really exciting. Well, and that's just with Red River Cardiovascular, right?
Yeah, it's actually for the hospital.
Oh, okay.
So
Nice.
it's a bar that the whole hospital has to meet to qualify for that.
Yeah, impressive. Okay, so we've talked about TAVR, MitraClip, Pascal, and then tell me a little bit about this tricuspid clip.
So that's there are 4 major valves, and the 4th one almost never gets bad. I've only done twice out of thousands of cases I've done. But this tricuspid is the 3rd most common. Again, it's very, very rare. Maybe once a year or twice a year we do something with it. But they have some technology that if it's leaking bad, we can fix it from the inside. It was released again 6 months ago, and we are hopeful that we'll be able to get it in the next 6 months over here. So
awesome. Okay, and so we've talked a lot about heart anatomy indirectly. So tell me, for viewers that may be unfamiliar with the different valves, can you kind of give us a little brief anatomy lesson?
Yeah. So the blood goes in from your right side, and it goes in through your tricuspid, which you just talked about. and then goes to your right ventricle, and then it goes to your pulmonic valve, then gets pumped to your lung where it gets oxygenated, and lung is also a good filter, and then it goes to your left side, goes through your mitral valve, then the left side kind of pumps it through your aortic, which prevents backflow. So that's the circulation. Then goes to your extremities, and wherever it gets oxygen gets sucked back, and then goes back to your lungs.
And it's all happening really quickly.
Oh yeah.
Yeah.
60 to 80 times a minute.
Okay, and so, but for someone that has heart failure, there's a weakening.
Oh, for sure, it slows down.
Okay.
So we've talked about the structural issues, the valves. You can have holes in your heart. We can fix them the old-fashioned way, which is, again, I do one of those every few years. But most time we have some shields we can put in from the inside without cutting you open. And there's some new technology called Barostim that just came out 2 years ago. And I think probably in Louisiana, Willis Knighton has done the most.
Wow.
It's really, really helpful for people. It was still in trial. I think it just got approved from prime time starting January 1st. So, which just means we have a code from CMS to actually say this is what we did. Before that, we were just using a learning code. So.
Okay, and can you say that word again?
It's called a Barostim. If you have really bad heart failure and you've tried medicines and your heart is weak, it's not pumping as well, we can do this implant that goes into your carotid, and it can help your blood. It lowers your blood pressure and it lowers your heart rate. It makes you feel better. Again, these are one of the most thankful patients I see.
Yeah, okay. And heart failure, it's a chronic thing. That's something that's built. Would you say it's built up over time, or are there some situations maybe where it's acute?
It can be acute. Most heart failure is chronic, thank God, because acute usually becomes an emergency. We have to do something there and then. With time, the valve slowly gets tighter before it closes, before we have to do something. Sometimes, especially in pregnant women or some really bad, some people who work out too much, they bear down and they can rupture their mitral valve.
Oh my goodness.
That's one of the acute things. Sometimes you can get an infection of your heart that can rupture one of the leaflets. That's acute, but it's very rare.
Okay, and so for the common heart failure that you were saying happens maybe in the elderly population, 60s to 80s, tell me a little bit about some of those. We talked a little bit about symptoms, but maybe how that builds up. And so you talked a little bit about maybe a healthy heart. So what does the heart failure heart look like?
So you have high blood pressure, or you can have high cholesterol. You can damage your arteries slowly, which makes your heart dilate. Makes you keep fluid in, which makes your heart dilate more, which the body's compensation for your heart failing. So it's a vicious cycle that can go. As surgeons, when we do the TAVR valve, we actually stop the heart from failing, and sometimes we can reverse it. When we do coronary artery bypass, that's the hope. When you get the blood back in those muscles, it can revitalize that heart, and it can make it stronger. PCI can do it too if it's not too complex. And also when we replace the valves or we fix it one way or the other, the whole hope is you are getting, your symptoms are improving. The symptoms are mostly shortness of breath, leg swelling, sometimes you can have palpitations.
And is there typically fluid restriction, sodium restriction when you are diagnosed with heart failure?
Yes, dietary is very important. That's the first line is medical therapy, and dietary is part of it. You need to fluid restrict yourself, usually 1500 cc's. You need to be on a beta blocker. Usually people will be put on a pink pill. There's some new Jardians that help really well too. Entresto is a new drug that came out a few years ago that's been a big time game changer. If all that stuff doesn't work and it's not something that we can fix with surgery, sometimes it's not, then you go for ICD, which is something that's like, it changes the timing of the heart, and by changing the timing of the heart, we can get a little more oomph. If you have atrial fibrillation, that means two of the chambers are not pumping in synchrony. If we can try to get that fixed too, meaning you can do some ablations and try to fix it, they'll get a little oomph. Or if the last resort is this Barostim we do, it can also get 10-15% and really make people live longer, feel better for a few years. But the end result is if we can help someone, they'll either need a artificial heart, which is a machine, You can implant on the top, or you'll have to have a heart transplant if you're young and healthy.
Okay. And so you did mention briefly just a second ago that in some cases TAVR or the procedures that you perform can reverse some of these effects?
Yes, ma'am.
Wow, that's incredible.
Oh, that's what we do. We want to help people. And we want them to get better, and like our caller, the first caller, they feel really great.
Yeah, okay. So I feel like maybe sometimes a misconception might be like, if I have heart failure, does it mean I have heart disease? Or is there a difference? I know you mentioned structural heart is more of the heart instead of the blood vessels, and heart disease maybe is more the blockage of the vessels, right? Or can you explain?
Yeah, you know, it's how you quantify it. Heart disease, I think, encompasses both the blockages and the structural heart, just some kind of disease. Okay. There is, sometimes heart failure is due to more issues than just a structural heart issue. It could be due to congenital abnormality. I guess that's structural. It could be a blood vessel that gets blocked, makes some muscle kind of get weak, and that can cause structural heart issues. If you just fix the blockage, a lot of times that muscle will get better, and that, it's a 3D structure of muscle. So if it's flagging on one side, it'll make it leak, but if you can get blood to it, it'll likely straighten out and the leak gets better.
Okay. And is there a difference between, heart failure and maybe the leaky valve that you were talking about? Is there different components to that?
Yeah, heart failure can be caused by leaky valves, but not all leaky valves are caused by heart failure, so circular argument.
So what I'm picking up is this is a very complex condition. It's not, you have to do a lot of different tests to kind of figure out what the best thing would be for the patient moving forward, case by case, it seems.
The first thing you do is medical therapy. First thing is actually diet modification. If you lose some weight, less sodium, eat better, eat healthier, exercise, you might be able to reduce weight. Each pound you gain, or 10 pounds you gain, puts a lot more stress on your heart. So just reducing the amount of work the heart has to do helps too. That's one option. If diet and exercise and lifestyle modifications, as we call them, are not working, we can try medicines. That's the second line. Medicines work, but there's compliance, which means do people take it on time?
Right.
Is it absorbed on time? Sometimes it works, sometimes it doesn't work. And that's where I think Barostim comes in. It actually is a mechanical way of doing the same things like medicine do, but it's always, it does a better job, I think.
It's right on time.
It's right on time, and you take your there's nothing to, if your lining is bad, you're not absorbing, you eat the wrong kind of food. The bioabsorbability of the food can, as you know, can go different, especially the drug absorbability. So I think that it takes that out of the picture. So after you try medicine, doesn't work, you can try this timing thing, doesn't work, and then you go to Barostim usually. After Barostim, the only thing that's left in our repertoire is some kind of replacement therapy. But if this is caused by a structural issue like a blood vessel issue or a valve going bad, if you fix it, most of the time people feel better, and most of the time if the muscle is not dead, if it's not scarred, it actually gets better.
That's awesome. Yeah, and so awesome work that you do, but then also, you feel like you lean into just the natural human body of the way that we're able to maybe, like you said, if it just gets better on its own sometimes, maybe after that procedure. So
body heals.
Yeah, that's awesome. Well, if anyone is out there watching right now and wants to maybe get in to see you, I know you mentioned within a week, sometimes you can see patients depending on, of course, holiday season. Yeah. How do they do that, and where can they find you?
Call us at 318-227-9777. Just ask for me, Mehmood, and we'll take care of you.
Okay, one more time, that number,
318-227-9777.
Okay.
A lot of sevens.
A lot of sevens, yeah, pretty easy to remember.
Yeah.
Okay, and so real quick, we have about 40 seconds. What are those devices that are going to be coming soon? You mentioned Barostim.
Sure, Barostim we already have. There's Evoke. Those are mitral valve devices. It's a valve that you can put in just like a TAVR. Right now it's a clip. We're just trying to approximate 2 layers. But it's a valve that can go in the mitral position, and something similar is coming for tricuspid.
Okay, pretty exciting stuff.
I know.
Awesome.
Good good time to be a heart surgeon.
Absolutely. Well, thank you, Dr. Mehmood, for coming in today, and thanks for joining us. This will be on ktbs.com/Healthline3.